So Rachel is with us, and she's Professor of Child and Adolescent Mental Health in the Department of Clinical, Educational and Health Psychology at UCL, and leads the UCL Child Trauma and Recovery group.
It's really nice to be here today. Thank you so much for having me out to talk today on some research we've been doing in my team over the last, quite a few years now, all looking towards this question of how can we increase access to best evidence mental health support for young people in care. And today I'm going to be presenting touching on work we've been doing for a few years now, but I'm also going to particularly focus on a recent project we've finished called the ADAPT project that looked at the implementation of a treatment called trauma-focused cognitive behavior therapy, but more on that later. Let me just move my own face off the screen. Okay, I've just moved your faces off the screen. So if someone needs me, do unmute and call out because I can't see anyone now, so I can see the slides. So I just wanted to start by setting the scene on what we know about the mental health of young people in care, but I won't labour on about this because I know there's a lot of experience in the room. I know my colleague Danithi has recently done one of these sessions, which I'm going to presume was about mental health given her research area. But this is just really to kind of set the scene of what we'll be talking about today. So there's a lot of research still to be done on the needs of young people in care and how we can get better support and how we can work with services for young people in care. But what we do know a lot about already are the mental health outcomes that can categorise this specific group of young people. There's enough research there that we've also got meta-analytic reviews that have brought together all the literature. So, for example, we know that at least half of young people in care meet criteria for a diagnosable mental health condition. So that means a mental health condition that would be defined in one of our diagnostic manuals. We also know that there are probably lots of young people in care that might be subclinical, but those symptoms still might have a major impact on their functioning and their well-being. Something to be particularly mindful of that we know for young people in care is that they tend to underreport on their mental health symptoms. So things that might look subclinical up under a diagnostic threshold in terms of their own reporting might actually be the product of underreporting, especially if you can see it's having a major impact on their well-being. So that's a kind of clinical consideration that's quite important for this group. We know that in general, this is a group that have much higher rates of all common and trauma-specific mental health conditions. So common being things like depression, anxiety, conduct difficulties, and trauma-specific being things like post-traumatic stress disorder, which I'll talk about a lot today, attachment-related disorders, etc. We also know that the profile of the development of mental health difficulties in this group tends to be chronic. So we did a project quite a few years ago now where we pulled the Strengths and Difficulties questionnaire, a questionnaire that I'm sure lots on the call know about. So we pulled SDQs for young people in care over their first 3 years in the care system. And we found that over 70% of those who have a high SDQ in the first year still have a high SDQ, or actually even worsening SDQ scores by their third year. So we don't tend to see a lot of kind of natural recovery from mental health difficulties that are there right from the first year they enter care. So I wanted to also upfront talk about some mental health myths that I think are still quite pervasive when it comes to how we think about the mental health of young people in care. And I say these upfront not to be controversial, and I hope none of my talk is really that controversial, but just to get us thinking about how these myths might persevere in practice and what it might mean for young people in care in particular. Myth 1 is that all mental health difficulties in this group stem from attachment difficulties, and that the attachment framework is the main framework that we should see mental health difficulties through. That is absolutely not true. That's not to say that there aren't young people in care with attachment-related disorders. We know that there are. But it's certainly not the most prominent mental health difficulty affecting this group. And certainly it would be a massive generalisation to think that everything for young people in care is related to attachment. There's simply just no evidence to support that. Another myth that we see a lot is that all mental health difficulties in this group can be described as developmental trauma. That is also something that I would heavily challenge. In fact, even for young people that have been through a lot of trauma, not all of their mental health difficulties will be trauma related. It's really important that we think about mental health in a much more nuanced way than that. And certainly the phrase developmental trauma is a phrase I'm going to come back to a bit in this talk about some of the challenges it might present for young people in care. And then the third myth that we see a lot is that the mental health of young people in care is completely different to other young people. We can't take any of our learning around mental health in general populations and apply it to this group. That is also simply not true. There's been a huge amount of work, as I said in my previous slide, about the mental health needs of young people in care. We know they fit the criteria for mental health as we currently understand it. We know they have far higher rates of common and trauma-related mental health difficulties. That doesn't mean there's not other complexities around the young person. Comorbidities are really common, but fundamentally the mental health needs of this population are the same as in other young people, just at a much higher rate. So moving through to a specific mental health difficulty, post-traumatic stress disorder. I will go into this in a little bit more detail just because everyone's come from different backgrounds to make sure we're all on the same page. So a lot of the work my team have been doing over the years has focused in on post-traumatic stress disorder, which is a trauma-specific mental health condition. So you can only develop PTSD if you've experienced trauma. One of the reasons we focus on this as a mental health outcome is that we already know that rates are very high in the children in care population. So rates are 12 times higher than it is in other groups of young people that don't have experience of care. And when we look at some of the smaller screening studies that have been done using standardized PTSD screening tools, we can see that anywhere from kind of 30 up to 70% of young people in care screen above a clinical threshold on PTSD screeners. The higher end is some small scale screening studies that have been done with children in care on CAMHS waitlist. So where we know there's mental health difficulties, we see very, very high rates of high PTSD symptoms. If PTSD is left unaddressed, it can be an incredibly difficult set of symptoms to live with. If we're thinking just in real terms that one of the most common features of PTSD is intrusive flashbacks and nightmares, where you feel like you're still in a lot of danger, where your memories make you feel like you're still back at the time when you were experiencing a lot of threat or unsafety. That would be an incredibly difficult symptom to live with when you're trying to sit in your math class or when you're trying to talk to friends. So if we don't address it, it is a symptom profile that is very much likely to get worse and affect other parts of your life as well. But one of the reasons I really like focusing on PTSD actually is because we already know a lot about it, we can do something about it. You don't have to suffer with PTSD. It doesn't have to be a lifelong condition. We have really good screening tools and we've got really good treatments. So that's always a nice baseline to work from, because it means if we can work out kind of what is going on, we can hopefully do something about it. But in general, I guess one of the messages I want to get through in all of the talks we do based on the research we have is that if you're working with a young person in care who is struggling with their mental health, it is very likely that they would meet criteria for a diagnosable mental health condition, whether that is PTSD or any other kind of common or trauma-related mental health condition. This is just to give a little bit more detail on what PTSD is. So this is the diagnostic classifications. So we have standard PTSD or PTSD, and that is 4 symptom clusters. So I've already talked about re-experiencing, that's nightmares, flashbacks of your experiences. Also core to PTSD, making it a particularly tricky diagnosis to work with, is avoidance. So not wanting to talk about it, not wanting to think about it, not wanting to be reminded of it. Pretty understandable, but we know is a core symptom of PTSD. Also altered arousal. So that's often things like difficulty sleeping, difficulty concentrating in class, and negative alterations of mood or cognition. So often it's low mood, thoughts like, I'll never get over what happened to me. Some of you might know that in 2018, a new diagnosis was introduced into one of our diagnostic manuals called complex PTSD. And this in some ways has confused things a little bit actually, because what I think really the only thing we need to know about complex PTSD is that it is still PTSD. So to have complex PTSD, you still have to have PTSD, but it's almost PTSD plus. So you would also have emotion dysregulation, quick to anger, difficult, taking a long time to calm down, relationship difficulties, negative self-affect, like I'm not worth anything. So where those features present alongside PTSD, we call it complex PTSD, but it is the same treatment, and actually the screening tools we use are often very similar. So we don't need to completely reinvent the wheel around this new diagnosis. One of the first studies we did around PTSD was really in response. We were working really closely with a lot of services for children in care to try to understand what was happening on the ground and what their needs were. And one of the things that was coming up a lot around PTSD was this idea of, well, you might say you know a lot about it, but that all of that literature is with other young people. Our young people are different. We don't really believe that that literature could be applied to our young people. And that felt kind of fair enough, actually. That a lot of the research had been done with groups that had been in one-off traumas, like a car accident or even a natural disaster, for example. And whilst there had been a lot of research in more complex groups, this kind of mechanism research or explaining the mental health difficulty hadn't been done in much detail in children in care. So one of the first studies we did was called the CAMHS project, and it really quite simply looked at, does PTSD look the same for other young people in care? What you can see on your screen now is a simplified model of what's called the cognitive model of PTSD. It's a very long-standing model developed by researchers in the UK. And we really wanted to know whether this model was applicable to young people in care. And why we wanted to do that is because this is the model that underlies our interventions in this area. So the model proposes that there are three components that are really important in maintaining PTSD severity and essentially maintaining this ongoing sense of threat. One is the nature of the trauma memories. So where memories are very confused or disjointed or muddled, that is said to maintain and worsen that sense of current threat. The other component is meaning. So what meaning do they make of their experiences? And this might be things like, so often we talk about it as a scary world or how you feel about yourself. So the world isn't safe for me. I can't trust anyone. I can't cope when things get tough. What happened was all of my fault. So the meaning that they make from their experiences. And the third component is their management of these symptoms, and that is essentially their coping strategies. So those the young people that are engaging in more avoidant coping, trying to push memories out, not wanting to talk about it, that is also said to maintain the current sense of threat. I think one thing to say at this point is that all of those processes are completely understandable in the context of child maltreatment. Memories will be muddled because of the developmental period that they've often happened over. It might have at some point in your life been really true that people weren't trustworthy, and that the world wasn't safe for you. And to cope with that, you might have had to push those experiences into the back of your mind. So these processes on their own are really very understandable for what we know some of our young people have been through. The challenge then, once you're in relative physical safety, is that these are the same processes that can maintain mental health difficulties, both in the short and long term. So for this project, we had 120 young people that were 10 to 17. They were all in local authority care. They were about half boys and half girls. They were predominantly white and predominantly in a foster placement, although we had all different kinds of placements. These young people recruited into the study from local authorities in the southwest of England, which is where I was based at the time. And really the key findings here, and the paper, I should say, oh, I don't know how to press backwards actually. So on the previous slide, and the slides will be shared, is the a link to the academic paper. And in that paper, there's some quicker summaries, including a blog we wrote with a care leaver, and a podcast that we did as well. So this is all freely available. So I'm not going to go into all the statistics on it, but just to give you the key findings from this work. Predominantly what we found here was that the existing cognitive model of PTSD was highly applicable to young people. It really was. So those three processes I was speaking about, they were all really important drivers of mental health in this group. But in particular, it was the meaning and the coping that were very strong drivers of PTSD and complex PTSD. So young people endorsing what we might call maladaptive cognitions or maladaptive appraisals. It was my fault, I can't cope, I can't trust anyone. These were young people that had higher symptoms concurrently and also when we saw them 1 year later. And similarly, those that endorsed more avoidant coping also had poorer outcomes when we saw them 1 year later. The same, importantly, was also true for depression and anxiety symptoms. So it's not just about PTSD, that these processes can be really unhelpful for general mental health. One of the other messages that we found, which I think is important to share, is that these processes were far more robust drivers of mental health than their pre-care maltreatment severity. So how severe their pre-care maltreatment was, which was taken from social worker ratings and from case files, was not a robust driver of symptom severity. What was much more important was the meaning they took from those experiences and how they coped. That is not a surprising finding in the trauma field. In other groups of trauma-exposed young people, that is a pretty consistent finding, that it's really about the meaning and management, not necessarily about the severity of the experience. And that's not to say that maltreatment is as problematic as a car accident. That it's not comparing those two. It's saying when you've got a group of young people that have all had high rates of trauma exposure, we shouldn't be using that exposure as a reason to work out whether they should be referred to mental health services, for example. We really have to be looking at how they're coping now. The other thing that really came out of the CCAT study is even though we were seeing children report very high rates of PTSD symptoms, no one was talking about PTSD. The young people certainly weren't receiving that as a diagnosis. Many were in mental health teams and weren't having conversations about PTSD. So this moves me on to kind of the main part of the talk. And that is really wanting to understand what helps and hinders mental health teams in the delivery of best evidence treatments. I hope I'm going okay for time. I should have looked at my clock before I started, but Ellie, you'll jump in, I think, if I'm...
Yeah, you're good, Rachel, you're good. It's 2:25.
What time do you want me to finish this talk, sorry, Ellie? 2:45, is that right?
2:45 or 2:50.
Right. Sorry, everyone. I should have looked at my clock before I started talking. So in terms of what helps and hinders mental health teams in delivery of best evidence treatment, just to say up front that when I'm saying best evidence treatment, I am talking about the NICE guidelines, the NICE recommended treatments, depending on what the mental health difficulty is. For PTSD, that is very squarely trauma-focused cognitive behavior therapy. This is by far the best evidence treatment we have for PTSD and complex PTSD. It's been used very extensively with complex trauma experienced populations, including specifically with research on maltreatment-related PTSD. In fact, trauma-focused CBT really comes from the sexual abuse literature. That's its origins. But there's also trials that have been done with children in foster care. Much of that work is from the US, but still highly applicable. So whilst often there is a myth that trauma-focused CBT is only a treatment for children that have had a one-off trauma and then go back to their happy homes, that's absolutely not true, and that's absolutely doesn't bear out in the literature. So a meta-analytic review that came out recently showed that trauma-focused CBT is as effective for children who have experienced multiple traumas as it is for those who have experienced one-off traumas. Other meta-analyses that are starting to come out are also giving further information for it, like, for example, that it doesn't lead to higher dropout rates compared to any other therapy. So one of the concerns with trauma-focused CBT is that children won't be able to tolerate it and will drop out at very high rates, and that is not what the research shows. Just to say also up front that the research also would show that trauma-focused CBT will not work for every young person all the time. No intervention does, and anyone claiming that should be a big warning sign. It's imperfect. The literature could use more work, but as it stands, it is really head and shoulders above any other approach for treating PTSD and complex PTSD in children and young people. So that is what I'm talking about when I say best evidence for PTSD. So when we're looking at the challenges services face, we want to start with how do young people actually come into services and how do we know what their mental health difficulties are? Our presumption is if you're not identifying PTSD, you're probably unlikely to provide a PTSD treatment. And here is one of the first challenges that I wanted to talk about, and that is how we screen for mental health needs in children in care. So we're running a study at the moment that some of you might know about. Some of you maybe have services involved in it called the Rethink Project. It's a 4-year program of research looking at the mental health and wellbeing of young people transitioning through early secondary school and into early adulthood. We've just finished the baseline recruitment for this sample, and we have over 400 care experienced young people in this study. We've taken that data and combined it with some previous data from the CCAT study where we used common mental health measures to have a look at how the SDQ works as a screening tool for young people in care. So as everyone on the call will know, the SDQ is used in all English local authorities, usually from carer report as it's part of the mandatory reporting to DFE. It's very rare that services would screen young people with standardized screening tools beyond the SDQ. Now, we already know that there is generally poor agreement between young people and caregivers on the SDQ, with young people underreporting, which speaks to the importance of collecting it from multiple people, not just carers. But that's also not necessarily anything to be too panicked about. When you do research with any kind of caregiving child pair, even a child with their biological parent, there's almost always a mismatch between how children think about things and how the adults around them think about things. So that's not a disaster, but it is worth noting that there's poor agreement. But perhaps more concerningly, what this research showed was that the SDQ misses over half of young people who have clinically elevated PTSD symptoms. So that means when we do a standardized PTSD screener, the young people who score above threshold, which was over half of this sample, most of them would be missed if we're just using the SDQ. So the SDQ is great for its purpose, but we really need to recognise that it is going to miss a large number of young people, and it's particularly missing young people with PTSD. We also did some other work a few years ago in a randomised vignette study where the participants were mental health professionals. So they were UK-based child and adolescent mental health professionals, and they were randomised to receive one of 2 vignettes. Now, these vignettes were a short description and they were identical. They described a boy who had experienced maltreatment and was presenting with PTSD symptoms. The only difference between the 2 vignettes was in one, the young person was identified as being in care, and in the other, the young person lived with their mum, but everything else was identical. And what this study showed was it was really one of the first studies to quantify what we've been told qualitatively a lot, that young people in care face potential diagnostic and treatment biases simply because they're a young person in care, what might be referred to as diagnostic overshadowing. So professionals that were randomised to the in-care vignette were far less likely to accurately identify PTSD. They were far less likely to endorse an evidence-based PTSD treatment. They over-identified an attachment disorder, even though there wasn't core attachment symptoms. But what the study also showed was how pervasively the term developmental trauma was being used by services to describe mental health outcomes for a child that had been exposed to this type of trauma. And this brings me to a point I want to make about the importance of language when we're talking about trauma and mental health. So when we have a trauma, that we categorize that as an experience that someone has had, but there's lots of different ways we talk about trauma. So we might just call it trauma, we might call it developmental trauma, we might call it complex trauma, we might call it childhood adversity. There's lots of different ways we describe that. Trauma can lead to a range of mental health outcomes or no mental health outcome. That is also an option. Many young people go through trauma and don't experience mental ill health. But of course, as we know, some do. And when we're talking about PTSD, the language can also differ. We might call it PTSD. We now have complex PTSD, but developmental trauma, as that previous work showed, is also something that's being used a lot. And there what we see is that we're in a situation where the experience and the outcome are being talked about with the same language. And this is something that I think is incredibly problematic. both because it doesn't give young people an understanding of what trauma is and how it might affect their mental health. But also there's no agreed definition of what we mean by developmental trauma. So what I think that is and what you think that is might be different, but also it creates this kind of postcode lottery where what your service and what another service might think of as developmental trauma might also be different. Because there's no agreed definition, there's also no agreed treatment or care pathway from developmental trauma. So as a term, I think it is really problematic when we're using it to describe mental health outcomes. People that are interested in this also might want to look at the UK Trauma Council, where we did a research roundup on the state of evidence. Developmental trauma disorder as a mental health outcome came from a single group in the US. It didn't make it into diagnostic classification systems, but that was in 2013. So the UK Trauma Council did an update of the literature since the DSM-5, but it did show there is still really no robust research to suggest that developmental trauma is a helpful diagnosis for young people. So moving on for the last 15 minutes to access to treatment. Let me have a sip of water, sorry. So here I'm talking about findings from the ADAPT project. So up until now, what I've shown so far is what we know about mental health outcomes, that PTSD looks the same for young people in care, but then some of the challenges with assessing PTSD and picking up PTSD, both in terms of the fact that we just don't tend to screen for it and that the SDQ misses young people with PTSD, but also that there are potential service level and professional level diagnostic biases where young people in care might experience further inequity, being less likely than their peers, even with identical symptoms, for receiving an accurate diagnosis. But what about actual access to the treatment? So the ADAPT study was a project we've just finished, and the main paper actually came out last week. And we worked with 28 mental health teams across 14 geographical localities in England. And we trained 24 of these teams in a treatment called cognitive therapy for PTSD. That is a type of trauma-focused CBT. It's the model we tend to use in the UK because it was developed by UK clinicians. But as with all types of trauma-focused CBT, they share common elements around psychoeducation, trauma narrative work, and cognitive restructuring. So just to say, actually, I should have said on a previous slide, how we see trauma-focused CBT in the UK and under NICE guidelines is that it's any kind of manualized or formulation-driven treatment that has shared core components. So sometimes it's called trauma-focused CBT. That is a US manual. It's cognitive therapy for PTSD, but it would also include things like narrative exposure therapy, which some services use, prolonged exposure therapy. So these all have common elements that overlap. So here we use cognitive therapy for PTSD. The 4 teams we didn't train, it was because they'd already been trained in the treatment. So 11 of these teams were general CAMHS, 9 were targeted CAMHS for children in care. And some of you that work in those services will know sometimes they are very distinctly NHS services, but often they sit very heavily in social care or somewhere between. We also had 3 social care-based mental health teams, other specialist outpatient teams where they saw lots of children in care, but that wasn't their only remit, and 1 inpatient team. So the participants here were just under 250 mental health professionals, and they came from a diverse range of professional backgrounds. The 3 most common professions there were clinical psychologists, social workers, and mental health nurses. So the data that I'm talking about today comes from 58 focus groups and 62 individual interviews, as well as service data, where essentially we trained services and then we followed them over kind of 12 to 18 months after the training to look at what helped and hindered in terms of their use of this treatment. And ultimately what we found at the end of that time was that about half of the teams were able to implement the treatment, but only a quarter were able to implement it with care experienced young people. So for the last, let me just check, kind of 10, 15 minutes of my talk, I'm going to focus on why that was. So here are the kind of 3 core things that differentiated the ability to implement versus not. Also on this list is assessment practice, but I feel like I've talked about that enough, so I won't come back to that here. One of the main differentiating factors between services that were and weren't able to implement was simply their commissioning and service setup. And I'm going to go into that in more detail in a minute. The other really core factor that differentiated services' abilities to implement or not was the culture within the service and generally the therapists and the team's belief. The other part I've got down there is the complexity of young people. And I really want to be really clear in acknowledging this, is that all of the services we work with are talking about this, that they are working with young people with very complex needs, often a lot of risk and safeguarding, placement instability, school instability, the whole picture of complexity. That is really important. Services need to be commissioned and supported to work with that level of complexity. But I'm not going to talk about it any further than that today because it wasn't a unique driver of implementation. So it's something that all services talked about. It was a universal challenge, but services that were using the treatment were still dealing with that complexity. They were just dealing with it in a slightly different way. So commissioning. A key finding from the ADAPT study was that most young people in care in England would be very unlikely to access direct psychotherapy of any kind simply because of commissioning and service setup. That is pretty frightening in my view, that we've got a population with a huge amount of need that are actually very unlikely to be able to access best evidence care. And also that teams within regions were often not aware of each other's commissioning practices or what the service offered. So what this often looked like was that young people in care, almost always across England, although not exclusively, there were exceptions, found themselves either in the social care mental health team or a specialist children in care CAMHS team. Now, those teams do amazing work. They are crucial to access to services. But it was also the case that in the vast majority of regions, those teams were only commissioned to work with the network around the child. They weren't able to offer direct psychotherapy. So they've signed up to the trial saying, yeah, we really want to try to do this work, but actually the commissioning just didn't allow it. But then what we saw was very few onward referrals to CAMHS, either because young people just weren't being referred through or because CAMHS were rejecting referrals. And obviously, depending on who you talk to, they have stronger opinions about that. But fundamentally, it meant that the general CAMHS teams that were implementing just weren't seeing young people in care. So they weren't implementing it to that population of young people. So this is really important in terms of thinking through the structures of our services. In terms of identity, culture, and therapist beliefs, this was another major driver. Firstly, the teams that implemented were those that had stronger kind of within and between service identity. So they had a shared understanding of trauma, they had a shared understanding of mental health, whereas for some teams that was still a struggle. Especially, for example, some of the social care-based mental health teams, they weren't necessarily clear yet on whether they were meant to be doing mental health interventions, whether they were a wellbeing team and what that meant. So we would have some services say things like, we try to look at a young person holistically, and that's why we struggle to use the PTSD screening tool. That was quite common from services that struggled to implement the intervention. And I think these are really important conversations for us to be having. Who is responsible for mental health? Because some teams would ended up saying, oh, we've decided we might just be a wellbeing team. But actually, fundamentally, they were holding the mental health of young people in care. So what does that mean for those teams? There was also differences in buy-in to evidence-based models of assessment and intervention. So teams that did not believe in mental health diagnoses, teams that don't believe in the use of CBT treatments with young people in care, I don't think it's a surprise that they would not be implementing. Teams that have a stronger buy-in to evidence-based practice and NICE guidelines, for example, are more likely to implement. And that really wasn't about professional background. So we have professionals from backgrounds that wouldn't have usually been training these types of interventions really take to the model. And we have professions that would have been trained a lot in these interventions really not agree with the model. So it's really not about background as much as kind of attitudes and buy-in to evidence-based models. And this came up quite a lot in services that weren't implementing. And that is also this idea that the service might not provide direct psychotherapy to a young person because they don't want to look like the child is to blame, or they don't want to locate the problem within the child. I don't think any of us want to have a child think that they're to blame for what they've been through or their mental health. But to me, this is verging on kind of professional stigma, where we are choosing not to provide best evidence practice because we're worried it might blame the child. But really, good quality psychoeducation should help a young person to understand that. And these are young people that often feel a lot of blame and shame. So I'm just not convinced that not offering our best evidence treatments is a way around that. But I'll be interested in other people's views. Supervision was key. So every team that implemented had strong supervision structures, and supervision was prioritized by the service leadership. There was no team that used the intervention that had weak supervision structures. So that really was fundamental. As was buy-in from leadership and the team. So you couldn't have one or the other. We had some teams that really wanted to use the intervention, but leadership gatekeeps young people in care off of that intervention pathway. We had some team leads that really wanted the intervention used, and the team did not agree with the approach, and that then causes conflict, which we don't want, certainly in our services. So you did need buy-in from leadership and from the team, and in particular a culture where the team works together in supervision to talk about anxieties they might feel, to talk about avoidance they might feel, and come up with strategies for really working with complexity.
Rachel, just to say you've got 10 minutes.
Oh, that's perfect. So I think I'm getting to my last slides. Thanks, Ellie.
Great.
So I wanted to finish up. I might even not take the full 10 minutes. I wanted to finish up with pulling together all of these different research projects I've talked about to consider what allows best practice, because it's really easy to get overwhelmed by all the things that are not working well and the struggles that I know are very, very much there in our services. But there are also amazing examples of practice across England and across the UK more broadly. The ADAPT project did focus on England, which is why I say that. So what allows best practice? Firstly, it's strong links between CAMHS and social care. And I can't imagine anyone is falling off their chair with that as a recommendation. It's certainly not a new recommendation. But what does that actually look like in practice? And these are the things based on our data that we think that needs to look like in practice. Firstly, priority access to CAMHS for children in care. This was very rarely the case. So some of our CAMHS specifically said they did not see children in care. I'm not sure that's always true, but that is what they would say. Or they would only see children in care for very specific reasons, like autism or eating disorders were the most common. Whereas we had some CAMHS teams where sometimes despite their commissioning, they really came together with their specialist looked after children CAMHS team or their social care team, and they organised priority access to their waitlist, to their assessment practices. So it absolutely can happen, and I think it should be happening. We also need commissioning that allows for flexible delivery of best practice. And that means flexible decision-making between teams that can make the decisions in the interest of the child. So for example, not swapping therapists because they happen to have moved into the eligibility of another team, for example. And that also means that the commissioning would allow time to develop trust, time for young people to disengage and engage, extended working after children have turned 18 years old. We had many children on ADAPT have to stop therapy simply because they had a birthday, which is shocking. And particularly some national considerations around how services should work with children in out-of-area placements. This is a real challenge for services. We also want commissioning that prioritises high quality assessment and formulation that includes the child. So current standard practice is that assessments for young people in care don't include the young person, that the information is taken from the network around the child. That means we're going to be missing a lot of information, especially in trauma-focused work, because part of the therapeutic process is helping that child to get ready for the therapy. They're not, I mean, sometimes they really want to talk about their experiences, but more often than not, they need a bit of time to understand the treatment, what the research is, what the purpose is, what it means for them. That in itself is a skill. So we really need to be making sure children, wherever possible, are brought into the room when we're talking about assessment and formulation. What also works best is when CAMHS psychologists are actively embedded in local authority work. And that might be that the local authority pays for it or NHS pays for it. But essentially it enables joined up working where they provide supervision or other support to the local authority team. And in line with this, there really needs to be a shared understanding of the language around mental health, which I've referred to a few times now. And in a practical sense, teams that were implementing well are often looked like regular, weekly or fortnightly, short meetings, 5 or 10 minutes between the CAMHS lead and the social care lead, where they would discuss all the young people in care on the CAMHS waitlist or receiving treatment in CAMHS. So all of the players know what the plan is for that young person and that there's agreed understanding of their needs. And then this question of culture and buy-in to evidence-based practice. What do we actually want this to look like? I've said it too many times, shared understanding and language around mental health, clarity on what the team can and cannot offer, and if they cannot offer it, which sometimes is the case, where that offer is coming from. So if that team can only do the network work, which is very important, where does the direct work come from? And making sure everyone's coming together to understand what the evidence is around that. The prioritization of assessment practices as well, and the prioritization of training and strong supervision structures, because without that, it is almost impossible for services to deliver really high quality care. Supervision also really needs to focus on problem-solving treatment barriers and not just case management. Services that were able to facilitate that were services that used the treatment more often. And I've referred to this before, but that open and non-judgmental environment where people can discuss anxieties, it's totally normal to feel anxious about delivering trauma-focused treatments to young people, especially when they have complex needs. We need supervision and services that can hold that anxiety and avoidance and work with it and not pretend it isn't there. And ultimately, the services that are implementing are really teams where you can see they're looking for reasons to provide treatment. It's very easy to look at all the reasons that you might think a young person is not ready for treatment, and some young people won't be, but sometimes we're making that presumption. What we want is for services to look for reasons to provide treatment. And the analogy I always use here is we want to build more ladders and less snakes. So final comments before I move over to what I always worry about what people have to say about this. But final comments here is that services, whether that's social care or CAMHS, have an almost impossible job because they're not commissioned to deliver best evidence, nice recommended practice. And that's something we need to be talking about. We urgently need to reassess commissioning for mental health services for young people in care, but we also need to clarify what our expectations and standards are of services. But I do also want to say that even amongst difficult commissioning practices and complexities, there are services delivering excellent practice and that are following nice recommended practice. We've got some great examples across England that we need to build on to solve some of the challenges. And ultimately, that children in care are children first, which I know people on the call will agree with. And within that, we have to recognise they don't all have the same mental health needs, and therefore there's not one solution to their needs. Sorry, I've spelled solution wrong there. There's not one solution, and any service set up with this idea that there's one silver bullet is not going to be usually using evidence-based practice. And as I said, more ladders, less snakes. So just to finish, the UK Trauma Council, as part of ADAPT, we co-developed some animations with care experienced young people around PTSD, trauma-focused CBT, but also how they might feel about accessing mental health support, and also how they might cope with really scary or distressing memories. They're all free to use however and as much as you want. And then I did just want to do a shout out that leading on from the ADAPT project with the UK Trauma Council and the Anna Freud, in September, we're going to be running an online and an in-person roundtable that is specifically for commissioners in England, and not just those that commission CAMHS services, but social care commissioners as well. The DfE and NHS England are going to have representatives at this, and it's a chance for commissioners to talk together about some of the challenges that they face and how they use evidence, and what practice is like for them. So if you are a commissioner or you know your commissioner, please do send this on to them, and you can email me for further information. And now I promise I really am finished. Thank you.